Greetings, everybody. I'm Dr. Karen Michell, and I'm the chair of the ICOH Scientific Committee for Accident Prevention. And it is my pleasure to welcome you today to our webinar looking at health-related events and whether or not those are being investigated in the workplace. I want to take this opportunity to thank each of you for joining us today. We really do appreciate your joining us. Before I go ahead and introduce our esteemed panelists today, I just want to start with some housekeeping issues. First of all, for this session, all the participants will be muted. We encourage you, however, to put any questions that you have in the Q&A box. The chat function is not available for questions and answers, so please be sure to use that Q&A box. I'd like to also just raise at this stage that we've had over 700 registrations for the event, so there's a good possibility that there will be many questions that we possibly might not be able to answer today in just an hour's period. So please bear with us. We will obviously get to as many of those questions as we can. So let me introduce our panelists to you today. I want to start by introducing Dr. Odette Volmink. She is an occupational medicine specialist based at the National Institution of Occupational Health in South Africa, and somebody I know personally. She is a fellow of the College of Medicine of South Africa for the past 10 years. Her role at the National Institute for Occupational Health has included clinical, teaching, and research roles in the Department of Occupational Medicine. Welcome, Odette.
Thank you so much.
Then I'd like to introduce Ms. Mireya Rifá Fabregat. She holds a master's degree in health and safety and is a member of both ICOH and IOSH, as well as being a member of the Specialist Association of Health and Safety Professionals in Spain. Since 2016, she has represented APOSOL in the European Network of Safety and Health Professionals Organization, ENSHPO, where she is currently the president of ENSHPO. Welcome, Mireya.
Thank you very much, Karen.
And next we have Ms. Susan Donnelly. She's been employed by the Health and Safety Executive in the UK since October 2001 as a health and safety inspector, specializing in occupational health. She's registered as a nurse and community public health nurse, occupational health, and a trained regulator with a number of health and safety qualifications. Susan has been involved with numerous complex health investigation and written specialist opinion on multidimensional health cases for the court. Susan, welcome.
Hello.
And then we have with us Dr. David Thomas, who is employed as a senior lecturer in occupational health and safety management at the University of Middlesex in the UK. He is a past vice president of IOSH and currently chairs the Environmental Waste Management Group. Welcome, David.
Hi.
And then sitting here with us today as well is Ian. Ian is one of the committee members of SCAP, and he's assisting us today with the flow of the event. Ian has worked in high hazard industries for more than 30 years. He is currently he's served as the vice chair of the Environmental Waste Management Group and has chaired one of the branches of IOSH. Ian, thank you very much for joining us today and assisting us.
You're very welcome. Okay.
Thank you. Right, I want to start by sharing just 3 slides. Sorry. Okay. Can you see my slide, Ben?
Yes, we can see it.
Right, perfect. I've really only got 3 slides that I want to show you. The first one that I wanted to show you is that we are very conscious of the fact that definitions for any incidents or events in the workplace setting differ not only from country to country, but they're also different from one organization to the other. So in lieu of that, what we're trying to do is just set a framework of operational definitions today. And so what we want to work with is the ILO definitions that have been proposed. First being that an incident is an unsafe occurrence arising out of or in the course of work where no personal injury is caused or where personal injury requires only a first aid treatment. Second one is an occupational disease, which we consider to be any disease contracted as a result of an exposure to risk factors arising from work activity, whereas an accident is an occurrence arising out of or in the course of work which results in fatal or non-fatal injuries. And then terminology that we're going to work with today, just for ease of understanding, is we are going to refer to adverse health events as being any negative or undesired impact on the health of the worker caused by work activity and occupational exposure. Now, with that in mind, I then also just want to look at some statistics and put the accidents and diseases into context. Late last year, the WHO ILO issued a joint report on statistics for work-related death and disease. And what was really significant in that report was that more than 1.8 million deaths and 89 million dailies could be attributed to pairs of occupational risk factors and health outcomes. What they do in their report is they, for example, take exposure to asbestos and they link it to asbestosis and mesothelioma as there being a direct correlation between the two. What is interesting is the 41 pairs of risk factors that they currently evaluate, 18 of those are directly related to accidents in the workplace. So in terms of diseases, we see that more than 80% of deaths are caused by occupational diseases, whereas less than 20% of those deaths are caused by an injury. And then even when you look at the dailies, we have 70% are caused by diseases and less than 30% are caused by accidents. So I think it's pretty clear that occupational diseases are and will continue to be a significant problem within the working environment. And just one other factor that I wanted to bring out of that report is when you look at the risk factors and you look at the largest attributable deaths, the top three are, first of all, long working hours, something that it probably wouldn't cross our minds to investigate. Exposure to particulate matter, gases and fumes, followed by occupational injuries. And then interestingly, the three health outcomes which have the largest work-related burden include chronic obstructive pulmonary disease, stroke, and ischemic heart disease. And I think what this does is it very nicely sets the scene for our webinar today. And I'm going to ask all our delegates at this point if they would turn on their cameras and unmute themselves. And then I'm going to jump straight in and then say that based on these statistics and what we currently know, Mireya, I'd like to start with you. Should the management of these adverse health events and injuries in the workplace be approached differently?
Hello, Karen. Hello to everyone, to the audience. Thank you to be here. First, one of the points that we usually forget as, OSH professional is that, health and safety management is a whole. I mean, we cannot separate occupational health from one side, safety from one side, hygiene from another side, economics, and so on. So everything is interrelated. And that's one main point, because usually many countries, we consider occupational health outside, for example, for the work of the safety, engineers and so on. So everything is interrelated. So one of the main point of the good preventive management is the risk assessment. So we usually not incorporate, which medical factors or health factors could be implied to the workers. So when we face you know, to the investigation of an accident or an adverse event, you know, we have to take in account in the investigations. Usually we use, you know, the root, the tree cause. We have to use usually the risk assessment and go to there and include all the health aspect in the investigation. We have to take in account that, you know, we have not only evaluate, you know, the health in a global way, but in the specific way of the worker that we are investigating, because as we know, all of us, you know, the specific characteristic of the worker will be influenced in the way of the disease they can get or about from the work. So with the cost tree method, we can include health issues inside, and that could be, of course, have be done between the engineer, of the manager, of the officer, of practitioner, and with the, you know, the medical services, occupational medical service. That could be include the nurse of the doctor, but the work should be together. So it's going to be the same approach, basically the same, but with some medical or health aspect should be included.
Okay, thank you. David, can I bring you in at this point? Is there anything you'd like to add here as well?
Yeah, that's it's the question itself is a complex one in itself, because you know, the outcome we want is a problem resolved and the risk mitigated or reduced. That's what we are trying to do. But the route to it, with a single adverse incident like that would create an injury, the management of that event is far easier to identify than maybe it's a health-related issue. The challenge with health-related issues is right back to causation and association. We get hammered with that one the whole time as a challenge. And very often, especially in smallest and medium-sized enterprises, to get enough data to actually say there's a causal link between it to go into the risk assessment. So I think the traditional 5 steps to risk assessment, or that happens in the UK, is to some extent inadequate because of the scope of it involved. We just look at the average health and safety practitioner, for example, their role, you know, 19.3% of adverse events are injuries, 80.7% are disease. I bet an awful lot will not be, they will not be involved in any process for disease. They'll be involved in the injury side. So the resources being directed in one direction where there's competence, because we're looking at job titles rather than people. But if we're looking at, maybe my area of interest has been musculoskeletal disorders in the waste industry, whereas if it's not accidents that matter, it's the ill health. The ill health is mainly musculoskeletal disorders in the UK. These are types of injuries that occur over a significant period of time. And so to do that adequately is weak. When I did my own studies in it, looking at local authority risk assessments done for designing systems, the MSD risk was put down as low risk and acceptable by someone, not understanding the differences and nuances. So the complexities, the amount of data you want, the people you need to speak to as a generic, because we tend to feed off to the individual too much, so that area. So I think the approach in terms of risk assessment has to be different. And if we are getting injuries and ill health, we have that difficulty of saying it's caused by something or associated by it. Because once we go into causation, we're into legal claims and whatever. So I think that I don't think we are anywhere near in the right position where we should be. And I think that the sad thing is, in many areas, we don't have the right people identifying and talking about adverse health events.
Right. Very true. Susan or Odette, is there anything interesting? Just the result of the poll, that 60% of our audience agree that the investigation should be managed differently for diseases and injury, which is, I think, what our panelists are alluding to here, which is, so Odette or Susan, would either of you like to add anything at this point?
I think if I had a comment about this, I would say, I'm not sure it's the risk assess process itself actually that's problematic. I think it's people's knowledge and how to apply the tools that are there. So I think the risk assess system works fine. but people do not apply it appropriately.
Ah, okay, it's very, very interesting, and I think that that's one of the things that David alluded to as well, is this the skills that people need to actually conduct the investigation. Odette, is anything you'd like to add here?
You know, I think it's so much more. It's so much more tricky when you're investigating the disease, and it's critical. When you showed us the statistics, it's staggering how it's a problem we have to tackle. But it's there's so many other things to take into account with regards to the diseases. In terms of the diagnosis of the disease and whether or not it's an established cause of the diagnosis that has had, and then also latencies come into the picture. And so we need, there's such an importance of having the right people and the right skills in the room when we're doing the investigation to make it an investigation that gives us information that would allow us to protect fellow employees.
All right. You know what, that brings me to my next question and one of my thoughts, because for me, once that diagnosis has been made, it's almost too late. The horse has bolted. You've had enough exposure that there's now going to be an extent of disability. So one of my questions is that we understand that those health events, an occupational disease, should be investigated. But what about at the level when we suspect there's an occupational disease? I mean, before a diagnosis is actually made, what is it that is stopping us from investigating these events? Susan, would you like to start with this one?
So I'm really going to follow on from what David has just said. I think because you don't have a good health risk management system, you don't recognise the risk, and therefore individuals that are companies, don't do anything about that because they don't perceive that the risk is there. So I think that that's actually one of the first issues. And then you've got things like, just as you always have, you've got personal bias, you've got cultures that are blame cultures, you have inappropriate information instruction and training and how to investigate. You have people that don't go down to the root cause. They just simply find a simple solution and say that's it. And if you haven't recognised that you've got an issue of latency, then to be honest, even though you're getting feedback, I see that all the time. You get feedback from the occupational health provider saying there's a problem. It isn't recognised in the workplace because they haven't run this right back through their system to the risk. So they just, but the example that I'll give you was I had 156 cases of skin disease in a company. Now that should indicate that something is awry somewhere. And if you actually followed where those skin diseases appeared systematically, you could see this particular chemical moving through the process. But because there was no understanding that that was a risk, this was a new chemical that they were using, its subsidiaries had been skin sensitizers before, but there just wasn't an acceptance of the risk there. This chemical moved all through the process, and one of the issues about this particular, I'm just giving you an example so you can understand it, is that it wasn't water soluble. So some of the PPE that they were using, they were consistently, although it was going through the wash process, you're still getting skin disease. These things need a group of people looking at them. One individual can't do that. You have to have a group of minds looking at what's going on. So it's these personal biases of protecting the company, protecting myself. My system works great. You have to have an open mind. So I'd say these are fundamental barriers, but it all goes back down to this issue of skill and recognizing your risk to start off with.
I think that's very true. For me, it brings to mind the thought, you don't know what you don't know. And often when, for example, a safety practitioner may very well do a risk assessment, has even read the safety data sheet, but doesn't understand, the terminology, for example, in the health division and of that safety data sheet. And instead of then consulting you know, we find that the risk is then omitted. Any other barriers, you know, other than the skills that you are aware of or have seen in your practice, Odette?
You know, I think that I even want to take it a step further. You know, you're saying that you don't know what you don't know. And oftentimes, even in our medical training, in our undergraduate training, we aren't trained, physicians oftentimes aren't trained to recognize work-related conditions. It's not a big component of our teaching. And this often only comes postgraduate or, you know, later on. And so oftentimes occupational diseases are under-recognized and definitely under-reported. And so your stats then just are even more staggering, because what is this, the tip of the iceberg?
Yeah.
So definitely there's you know, there's that problem. So if as a physician outside or GP outside in community practice and you seeing musculoskeletal, maybe you can identify it to a workplace condition. But if you're seeing an asthma, and you know, they say 10 to 15% of asthmas are work-related, but if you're not linking it to the substance in the workplace that could be the causative agent or exacerbating the condition, you're going to treat inappropriately, and these conditions aren't even going to be recognized, you know, in the workplace if there aren't systems in place.
Yep.
So I think that definitely is an issue. And then, you know, we always say that we have a safety culture and we deprioritize the health. And, you know, that's definitely a barrier. And, you know, I think there's, like Susan mentioned, the time to do these complex investigations, and the expertise sometimes is lacking, and we don't source them from the right places. And you know, this it also needs, you know, this multidisciplinary team approach to doing a workplace investigation in these complex scenarios has to be, you know, there has to be a big cooperation, and it needs to sort of be seamless. You know, and the outlook of not having a blame mentality, but looking at, you know, what's underlying, what are the root causes, and what are the, you know, the systemic causes of that's increasing the risk, and how can we mitigate it, needs to really be the focus. I know in my early days, we used to look at one of the few health conditions that we investigated was TB in healthcare workers. And, you know, even looking back, we did such a shoddy job of it because we didn't have a multidisciplinary team. So many of the things we sort of just did sort of willy-nilly, and didn't get as effective. The results were, you know, we didn't really put any preventative measures in place, really looking back. So I think those are some of the issues that definitely have a role to play.
Thank you. At the panelists, are there any other barriers that you've possibly identified, David?
Can I come in? Yeah.
Yes.
Interesting barriers. I wanted to pick up on some things as well. We're talking about designing of work. So, you know, your risk assessment starts before you design the work. Why are we still designing 12-hour shifts in the UK? Why, you know, when we know that above 8-9 hours you get more accidents, and of course ill health deteriorates, yet we're still having companies that are relying upon 12-hour shifts. I wonder if the barrier is we don't talk to the workforce enough. I mean, three parts of the Health and Safety Work Act in section 2 is about workforce engagement. Why we're not engaging? You know, for things like MSDs, the hint of pain before absence is something we should be talking about. You know, if someone's getting aches and pains and a whole group of workers is doing it, don't wait for them to go sick. Start thinking, let's do an intervention now before the problem happens. I don't think we're far enough ahead. I think the third one, the barrier, is that people keep thinking, companies especially, we need a health and safety person, sort out health and safety. Well, there's no such thing as just health and safety. It's two words that are dumped in together. Different parts of the world have different, I think Switzerland and China, you have specific routes for people who are occupational health professionals in those areas. We should, in the UK, within IOSH, hopefully can change it. We can start looking at maybe our diversification of the profession. But we have that already. If I have an issue with dust or whatever, I don't want to help I don't want my budget going to a general health and safety person. I may want an occupational hygienist and some occupational health support to be brought in there. I'm going to manage my budget. Back to something the Judith Hackett said many years ago, you know, the duty holders should be understanding their own risks and get the expertise in that they need to do. I'm not sure that happens, and I don't think it happens in the design stage.
Yep. I think that's a very, very valid point, and is reiterating, I think, what our other panelists have already you mentioned, is that multidisciplinary approach is just so important. Mireya, before I go on, is there anything you'd like to add here? You're on mute.
Sorry. Okay. I can speak about this, my personal experience coming from, you know, Europe countries, and especially from Spain. You know, in Spain, what are the barriers? The main barriers are that we really don't, you know, classify all the occupational disease, and we don't really report all of them, because there is not, you know, when you go to the national health systems, you know, and you report an illness or a disease, they are not usually classified as occupational disease, because the national system is not, you know, linked with the occupational health system. So maybe I have a cancer coming from, you know, because asbestos, but they are not usually related to the, you know, to my work, you know, and that's a main point, because if the national health system is not linked with the occupational system, you really have a lack of information between, you know, the workers, the company, and your health. And the other barrier we have here, I have found many times, is that when I have the latency of the illness that, you know, Susan have commented, you know, we have maybe 10 or 15 years. During this time, I can move maybe from 10 companies, you know, and my occupational history about how it has been my, you know, my health during these 10 years is not coming through all the companies. So once I arrive to another company, they have no idea what I have been doing before, I have something, because there is no relation, occupational, national systems, or between companies. So that's a lack of information again, that, you know, if I go to a new work, and maybe I have a latency of a cancer, you know, plaque, whatever I have, and I start a new work with a new risk that maybe, you know, if it is not in consideration my historical and my medical history, you know, it will be aggravated, my illness. So this is a big lack. And I don't know if in UK you have these problems, but we have really here, you know. So I think this is a big barrier we can find in that point.
Mireya, I think you're describing a characteristic that we see with a large number of countries globally, that disconnect between the public health system and the occupational health. I just wanted to pick up on one of David's comments, when David was talking about how we should be talking to the workers. In my opinion, one of the important things about occupational diseases is that for many of them, those early signs and symptoms are exactly the same as a cold and flu, or maybe a little bit of gastroenteritis. And so often we miss that ability to pick up on the early signs, because the workers don't understand that there's the possibility that this might be associated with my workplace. So I think, yes, you know, getting back to the workers and educating them about, you know, what they're working with and what they can expect is a very, very important thing. But I also know that employers don't like us to do that, because then it's almost as if we're giving the workers too much knowledge, and they have fear that, you know, that everybody will now start complaining. But so I just wanted to pick up on that. And then the other one that I wanted to pick up was on Mireya's point about the fact that there's this latency and when workers move from one employer to the other, you know, there's a lack of transferability of that occupational health history. And I think there's often this mentality that the employer wants to say, well, this is my responsibility. I'm not worried about what happened before. But for that worker, it's actually a very good opportunity to identify at an earlier stage when a disease process might be kicking in. I think those are all very important. And one of the ones that I want to pick up now is this multidisciplinary approach. So if I said to you then, based on this, and who should then be conducting the investigation? Mireya?
Well, usually, you know, from my experience, usually, you know, we said, you know, this is occupational health. You know, doctors, nurses should take care about that. But that's not true, you know. Doctors, nurses, they don't have knowledge because it's not their role about mechanical or chemicals or, you know, many things, movements from the workers. So who has to take care, you know? A big team, because a big team that they know the role of each of them inside the team. And when we evaluate or we you know, do the investigation and we analyze all the causes that could have happened because of the accident or injury or the event, adverse events, we should work together, you know. Usually we have doctors here, nurses here, and safety officers there, you know. We are a team, I mean, and when I say in which is your profession, I say OSH professionals, I mean occupational health and safety professionals. So that doesn't mean that I have to be a doctor. No, that means that in my profession, in my role, you know, I work with people specialized in health, with people specialized in hygiene, in safety, in mechanicals, or whatever. So if we want really make a good prevention management or in our workplaces, we need to work as a team. Even though if they are external consultants, it doesn't matter, you know. People must know, or the specialist, the professional must know what is happening inside the workplaces, what is affecting the workers. So if we don't work together, so it doesn't matter if I am analyzing only because someone has cut their finger with, you know, the engineer. Maybe we don't know they have Parkinson. Maybe that's something, it's not, you know, it's so strange, but we don't know because nobody have considered this possibility on the workplace with this kind of worker. So we are a team and we have to work as a team. And this is so hard because there are so many different minds, but I think it's the only way, you know, to work together, all the professionals that take part in the health and safety professional.
All right. Susan, can I bring in anything that you'd like to add to Mireya's comments?
So I am very familiar with the UK system, and obviously I'm a regulator, so I've made some assumptions I realise as I listen to people talk that I just want to clarify. I don't think I talk about health risk management system. So within that, I am assuming that the company or the set of companies that we're talking about have agreed how they're going to deal with health issues. And to do that, they have to recognise them and then have a clear process of where the competence in each element of that is coming from. So I would never recommend somebody goes to the GP if there's a workplace issue that needs to be addressed. That has to go, you will involve a general practitioner or the hospital for diagnosis purposes, but you must have a competent occupational health person that looks at that. And they can only do that having had all of the information from the workplace. And if that is from the engineers, the designers, the occupational hygienists, all of those people that highlight what that risk is, you have to have that system because, and David said it right at the beginning, and that's the premise with which we should all be operating on, is that this occupational health system is to feed back and tell you whether the controls in the workplace are working. By the way, it keeps the employee safe, But you want to make sure that those controls are working all the time, so that, and that you evolve, so that, you know, if you consistently find a problem, you evolve to try and eliminate that. That's the whole premise of what we do. In the UK, when you're exposed, you have to keep the records for 40 years. So, you know, and if people move companies, well, that should ideally go, normally they'll ask them if they want to take that to their GP, and then when the occupational health provider gets involved with the next case, they can go back and see what they were previously exposed to. But that company is legally obliged to keep that health record for 40 years. And so when you have things like, if you look at silica, you know, we've got guidance in the UK. If somebody's been exposed over a 15-year period, so this is about occupational health taking a good history, then that person will get a chest x-ray to start off with, and then it'll go on to a routine system of health surveillance. So when we were having our discussions earlier, I probably was too superficial, because when I talk about this health risk management system, that's what I expect to see, a closed loop coming back all the time, you know, with ill health feeding into what your control system is. And if that doesn't work, if you go and send it to the GP or the hospital and you get no feedback, well, what use is that doing to you or the worker? And I just assumed, I have to say, that because we expect it in the legislation, that there is a health and safety representative, so a worker, you know, that's on that panel, because they'll tell you, you know, the beauty of human beings is that we're clever, and they'll do all sorts of things that you didn't realize they were doing. And that's what your health and safety rep will tell you, how it's actually done, not how you think it's done.
I think that's a very important point, Susan, because you know, I think that there is an assumption, because the legislation is there, that things are being done, and the reality is they're not being done. I mean, the ILO guidance, for example, says that you know, all medical events should be investigated, but we know they are not. So, you know, and I think one of the things that you have also eloquently already done today is vocalize why in many cases those assessments are not being done. But I'm going to just branch a bit here, because for me, one of the challenges, and I'm wondering if you guys have got something to comment on this, is that we know that there should be this collaboration between the disciplines within occupational health. But one of the realities is, especially for SMEs, they don't have these resources available. Is there anything in your experience that we can suggest to actually to improve this collaborative approach, but especially for SMEs with limited resources? I don't know if anybody has worked with SMEs and their ability in the past.
Can I take that on
Yes.
with one experience? Many years ago in the UK, the HSE was doing an exercise called Estates Excellence, which was getting non-health and safety inspectors, so non-inspectors, i.e. health and safety professionals, going into local authority, going into small companies enforced by local authorities. So you're looking at small businesses and micro businesses.
Yeah.
And during that phase, I picked up a couple of things that, the first port of call for many organisations is an HR person. If they've got a choice between needing HR support and health and safety support, they'll go to the HR support first to make sure they're managing their people okay. So I think there's a degree of communication with the HR profession, you know, that the HR profession needs to know that all these different professions are out there. The second thing I picked up actually was, for many of them, for purely workplace safety, we'll say primarily was the issue, but there was safety health in there, is look at your insurance company's website or your bank's website. I found some with Barclays with health and safety advice on there. So it's making these small and medium businesses aware that there is information there. It does appear there. And from that, really, it's maybe finding out or working with these people to actually make it sure that maybe you don't need a health and safety person, maybe you need an occupational health nurse, maybe you need a hygienist. It's maybe some better signpostings of what you have. But when we did a piece of work talking to people who are behind brand new business startups, health and safety doesn't appear on the agenda.
No.
Surviving kind of survive 3 or 6 months. So I think in context of that question, I think we have to be realistic that it won't get on the agenda despite how hard it is. But once you go in and see people, I went to see one small company that made plastics for Formula One racing cars. I thought, I'm not sure what this is. There were health issues there, I was sure, but I saw ventilation, I saw control measures, and when I spoke to people, they actually understood the risks out of their processes. So that gives me some confidence that in some technical areas, people do have knowledge and they do ask the right questions. But we've always said engagement is difficult because there are thousands of micro businesses and small businesses that have risks. That's my contribution. It doesn't answer the question. It maybe makes it less negative than people might be fearful of.
Yep. But I think you're right, David, that there are so many resources available on the net that it's a good starting point. I'm very conscious of time, so just very interesting here. The poll outcome, 33% of our audience saying is that the occupational medical practitioner should be doing the investigation, and yet 36% say the safety professional. So that's an interesting split.
Karen, I'd be interested to know how many people who wrote other actually meant a team
Yeah,
effect,
yeah.
because again, back to this, we tend to communicate by email a lot and we have data protection issues, especially with individuals. But I found that some of those productive conversations with other professionals have been on the telephone. It is a conversation that can very often narrow things down that maybe email exchange can't.
Yeah.
The thing about health interventions, in most cases, because the latency appeared earlier, it kind of has got the immediacy and urgency as maybe an electric cable having a problem or a guard not being fitted. The scope is different, but the nature of the questions is different.
Yep. I'm conscious of time. So Ian, I'd like to bring you in here and ask you, are there any questions that we have from the audience we can pose to our panelists?
Yeah, I think the difficulty is there's a wide range of questions, and maybe afterwards it would be worth addressing those in a feedback, written feedback to the participants. But one that has come across very interesting is, are there HR, human resources implications when we're looking at health records of staff? And the other one, which is something that David raised, which was about health by design, is anyone developing any support with respect to health by design?
So I'm going to start with the first question, and Odette, I'm glad that you've been able to join us again. Odette, the question is basically along the lines of, are there any health and human resource implications for access to medical records for an occupational disease? And I think this one falls very nicely into the field of confidentiality. Can you offer some advice there?
Yes, no, I think that definitely there are big issues with confidentiality, and in the occupational health space, it's tricky to navigate your dual role with regards to ensuring that you secure the patient's medical information, your employee as a patient, and also with regards to walking the fine line between what the employer needs you to be done and protecting the rest of the workforce as well. And I think that sometimes that's, if we break those confidentiality issues that are, that we're bound, ethically bound by, professionally bound by, and even within the legislation, we are bound to uphold those ethical values. It does place, the additional tasks that you have to do as the occupational medicine practitioner, and the trust for, that you have with the workers, it jeopardizes that. But you also need to have knowledge, and especially when we're taking it back to the investigating team, it's so important to have health members on the team, because they're bound by the codes of ethics, and so don't need to disclose that Mr. Smith has occupational asthma, as well as cardiac disease and HIV and whatever else. But they are aware of the health effects, and they can put it into perspective, looking at, you know, what the employees present with. So I think we still need to be bound by the codes of ethics. I mean, you still need to practice within that. But you know, that's why the role is it's a tricky role to navigate. But the knowledge of just the general knowledge, and we don't have to divulge specifics, is important in the team, I think.
Thank you. Susan, anything as a regulator that you can maybe add in terms of handling of the workers' information?
So I think you have to make sure that you understand that there's two pieces of information you're going to get. You're going to have your health record, and I'm talking about UK law, so I'm not sure what the rules are for other people, but in UK law, the health record is not medical in confidence. It says somebody's fit, unfit, or fit with restrictions. And you have to have that because this is going to allow you to comply with the regulations, which means if you've got an unfit or you've got some restrictions, you have to go back and review your risk assessments. So that's a legal requirement in the UK. If you are looking at medical in confidence data, and you will need to have some element of that coming through, because obviously, you know, if you're going to have a diagnosis, you have to say what the diagnosis is. That's about getting the appropriate consents. And once that's held by the business from a HSE point of view, that is a document that the business uses to manage that individual and its workplace risk. So that's how I would see that. When doctors are involved, and they should most definitely be involved in these investigations, they understand. I'd be very surprised if any doctor didn't understand, you know, all of the ethical implications and things that they are there for. And now I'm going to be a little contentious. Sometimes HR don't totally understand all of those. So I think this is about getting your systems in place so everybody understands what the roles and responsibilities are, and what information can be shared and what information can't be shared, and what you would expect to get from the doctor and what you wouldn't. And that has to be agreed in advance, I feel.
All right, thank you very much. David, are you able at all to address this question about the health by design?
Health by design. Yeah, what it means is you actually look at your broader risk to design your and design the activity around it with options. There is, for example, for the HSE did something in 2016, or HSL, Contract Research Report 609, RR 609, I think it is, looking at evaluation of waste collection services, actually looking at that and actually trying to design your waste service around looking at health, and it looks at health and safety issues. And the piece of work I did, I looked at the MSD element from that. I compared it with self-reported pain. I compared it with absence for different jobs. And guess what? I got some correlation that if people are doing a job where they're going to be bending, twisting, lifting, for example, food waste in the UK, or boxes and baskets, they would get more back pain and more back absence than somebody who's pushing and pulling wheel bins that have only got relatively light material. And you kind of expect that from common sense. So that's an easy example to use, but that's what I mean by comparing different systems, to make some choices earlier on. You know, businesses only get the chance to spend the money once. And it's kind of a good idea for a service that could be designed for 10, 15, 20 years. I think it does need extensive due diligence with that. And I want to pick back, when I looked at, I mentioned comparing absence, it meant I had to have access to records. When I talked to other health and safety professionals saying, do you have access to your company's health data for whatever, or can you make it available? Can you put it in a form? Many of them tell me that HR won't let them near it, even though it's in the organisation. Susan is spot on, I agree with 100%. It's organisational data and professionals in that organisation for the purpose of managing the organisation's risks. I think under data protection legislation, GDPR in the UK, I think they're entitled to look at it. I had one comment from one person who was a safety professional saying, if I was in HR department with the same job, I'd be able to see it, but because I work in environmental health, they won't let me see it. I'm a different council department. And when you're seeing that level of bureaucracy being imposed with a potential fear, I think, of litigation on GDPR, it doesn't help us. And I think maybe a piece of work, Susan, you and I, maybe something out there on guidance for this, for actually navigating what our perception, navigating a way around GDPR to actually get data and start to use the data you've got to inform the risk assessment, which is kind of what it's all about.
Yeah, yeah. Thank you. Ian, any other questions?
Yes, one interesting one that's just come in, looking at lifestyle audits. I suppose the issue there is that some occupational diseases, if you look at, for example, noise-induced hearing loss, can be as a result of exposure outside of the working environment. So the question posed there, are lifestyle audits necessary in the investigation process of an occupational disease? And I would add, not just in terms of noise-induced hearing loss, but generally.
Yeah. Who'd like to field that one? Odette?
I'd like, yes, thank you.
Yeah.
I think that's a very interesting question, a good question. I think that, you know, even as part of, you know, when you're assessing for an occupational disease, you need to take into account the exposure outside of the workplace, be it hobbies, be it, you know, in our setting, we have quite a big informal economy. So if people are doing work on the outside, you know, it really does. It has a role to play, but at the same time, you know, you have to manage this with, you know, the length of the exposure. Just say for noise-induced hearing loss, how long? If somebody has been working in a noisy workshop for the last 20 years, you know, with exposures over 85 decibels. You know, has occasional disco, you know, was going to the disco once a week for you know, a period of 4 hours. You know, we have to balance that exposures. We need to note them, but you know, it's on a balance of probability that we make the diagnosis of an occupational disease. So that means that, you know, is it like a 51% chance of it more likely being caused by the work, or the work having a big component of causality? And then in those cases, we would then go on to call it an occupational disease. So I think it's important to take those things into account, but we need to assess the entire exposure.
Can I share a very quick example? And this goes back to the last century, but very interestingly, I was doing some work with an employer who exposed workers to lead. But when I say exposed workers to lead, all the relevant controls were in place, and for all the workers bar one, all the biological monitoring results came back within perfectly acceptable limits. But one individual, you know, Joe Soap, his lead levels were elevated, and investigation in the workplace couldn't sort it out. And the long and the short of it was that they then went back to lifestyle and started doing some digging. And this individual was doing exactly the same as what he did at work, but at home as a way to generate extra income with no PPE. So he was being controlled for exposure at work, and he was then being exposed at home. It had a good outcome because the company, you know, were able to assist, and they got involved to turn the problem around. Probably because the management of lead in South Africa is far stricter than a lot of the other chemicals. So yes, in my experience, those kind of activities that workers do can have a significant impact on what we are seeing in the workplace as well. Right. Ian, have you got any other questions?
Yes, just going back, I think a comment which needs to be made and a question. So one of the comments that seem to come across is many professionals don't have the required occupational health knowledge when it comes to identification and investigation, and don't understand the relationship between work and symptoms of occupational adverse events. And so that's maybe a question there, maybe a comment. But the other aspect is the risks of ill health, again, are not fully understood. So should there be greater emphasis on monitoring workplace health as a whole?
Mireya, I want to bring in, do you have any comment about the knowledge, the fact that many of the people who are doing the, who are involved in the investigations don't have the right knowledge? Any suggestions or comments there? You're on mute.
For example, here in Spain, we have a lack of occupational doctors. So that means that usually sometimes, the occupational medicine is practiced by, general doctors. So this provokes that there is a lack of knowledge, specific knowledge of what is happening on the workplace. And the other thing is that what I mentioned before, the medical doctor, maybe through questionnaires, maybe through protocols, medicine protocols or whatever, they should be aware about what is happening on the workplace, what is related to this professional, what is related to this specific worker. If you are analyzing or checking some worker coming from a company or an industry, whatever you want, maybe, for example, tourists, and you are not taking in account, for example, MSAD, not only for the housekeeper, even though for the waiters, even though you have a lack of knowledge. So you must know how is their work, how they work, how they do the things, or at least be informed by the OSH practitioner telling you how is the work. But the best way is to know what is happening, because even though this is a hotel and this is another hotel, they are maybe not working the same way.
Right.
They are making not the same machine, the same everything. So it must be specifically for each company.
Thank you. Who'd like to field this one? Should there be greater emphasis on the health-related issues? I think we all agree on that. That really is very, very important. Ian, I think we have time really for one quick question.
Okay, and again, this has come in and probably very appropriate considering the recent past and still with us in some respects of COVID. So with home working or hybrid working now the vogue and on the rise, does the panel think that there's going to be a rise in ill health? And if so, how can this be monitored as it's still being classed as a workplace?
Susan, can I bring you in here as the regulator?
This is a horrible question.
I know.
I would say to you, so I think you've got two, well, actually, you've got a number. Stress has got to be one, and musculoskeletal. So I think the musculoskeletal element of your DSC, I think companies have really got to get their head round making sure people have the equipment that they need. David might disagree with me. I think that's the easier of the two. I think when you start looking at the stress issues, this issue of working long hours, working later into the evening, not being able to switch off, phone always on, it's got its pluses and minuses, hasn't it? Because you can be at home and it gives you a little flexibility to take, a half an hour off to hang the washing out, cook the dinner, do whatever else it is that you want to do. But then it's got this other, and I certainly know sometimes I do, it's sort of this insidious thing where you think you'll just work till 6 and 9 o'clock you're still there, or 10 o'clock you're still there. So I think they're going to, then it becomes problematic because you've got this monitoring system, haven't you? They can monitor how long you use your laptop for, what you're doing with it. Then people feel that's invasive of your personal rights. I think it's, I can't answer this question. I think it's quite difficult.
Yeah, do you know what? And I'm afraid we're going to have to leave it at that note, because our time is almost up, and then our link will be disconnected. I think in summary, I'm going to say that I think what we have drawn a consensus on today is that we don't have enough knowledge, and the knowledge is critical. That this needs to be a multidisciplinary approach, and that we need to be investigating all of these adverse health events so that we can put preventive controls into place and hopefully decrease future incidents of occupational diseases. The importance of the risk assessment has come through, which again I think is very important, how there's a lack of bringing the health element through on the risk assessment, which I think it needs some attention. And with that, I just have to say a sincere thank you to my panelists, such a knowledgeable group of people. It's been my absolute pleasure to share this forum with you today, and thank you so much for giving of your time. And to all the delegates who actually participated today, thank you very much for being with us. We'll have a look at the responses to the polls. And if there are some questions that we can give feedback, we'll kind of send it out as a communication. But to each of you, thank you very, very much, and have a good day further.